right. I hate it, guys. You like rabbits. You understand that in this time you will have the food and you start to move your jaw. Listen me, please. First of all, we must work with the terminologies which we have in the medicine. Ectomy is complete removing of some structures. Cholecystectomy, gastrectomy, appendectomy. Let's say this is completely removing of structure. Cholecystectomy means removing of the gallbladder. And first of all, we should understand together. Of course, again, that is not my question. But generally, I must understand why I do it, for beauty. If I will remove gallbladder after, we will be more healthy. We have something which is non-important? Of course, no. That's why any surgery, guys, should have very exact indication. Otherwise, you will be, remember please, how we can choose any kind of the treatment. I told it before. If the treatment, remember please, it is very simple formula. Have the benefits more than possible complication. Once again, if the benefits of your treatment is more than possible complication, then I say complication, I include here, and complication if you will not make the treatment. And complications which you can achieve by your treatment. Anyhow, if it will make situation harder than before it, such kind of treatment will not be used. And vice versa, if the treatment resolves the problem, I cannot say in 100%, but make situation better. Better, guys. Sorry, then you violated and cut the structures. Anyhow, you make some complications. That is impossible, you know, to cut the structures and make the person more happy and healthy. That is impossible. That's it. Then you ask the questions like, sir, but what will be after removing of appendix? I say, what will be if you will not remove it? The person will be die. What you can compare with mortality? Let's say switch your brain, guys. Not only this equipment is important, but that one also. Let's say again, I tell you, we make the treatment only if we know that its benefit is more than its possible complication. Now, I will understand now what is the benefit of my surgery, why I remove the gallbladder, and if I will remove it, what I will achieve, and vice versa. If I will not remove it, what will be happen? First of all, I must mention that the problem which is need to make this surgery, generally it is inflammational problem. This is the problem which is called cholecystitis, inflammation of the gallbladder. It's not the single, by the way, cause of this surgery, but it is the most usual. There are another causes also, trauma of gallbladder, or for example, malignancy of the gallbladder. That is also the cause of this surgery, but much more usually, we can see inflammation of the gallbladder, which is called cholecystitis. Itis usually show inflammational problems. There's a for example, appendicitis, it is inflammation of appendix. Gastritis, it is inflammation of stomach. So, cholecystitis. Now, let's imagine, guys, situation when gallbladder is inflamed. First of all, we must understand what is usually cause of this inflammation. That is the problem which is called gallstones. Gallstones, it is formation of the crystals, stones, inside of the bile. Bile, it is the viscous liquid structural unit. It contains several structures. Mainly, it is the acids, bile acids, pigments, some salts, and it is hyperosmotical liquid, hyperconcentrated. And you know that inside of hyperconcentrated some spheres, we can have sedimentation. I think in your school you make the simple experiments, yeah? Then you take something with hyper concentration, some liquids, you put some crystal inside of it, yeah, and it gives the sedimentation, yeah. All the salts, for example, sedimentated and forms the big some concrements or crystals, call it how you want. So we can have some disorders. It can be connected, for example, by metabolical changings, by inflammational problems. Primary, for example, there are the damage of some mucous membranous structures. It gives the place for the sedimentation. And if we will have changings of concentration of some structures, salts, I don't know, bile acids and something else, we can have formation of the stones. Next year I will teach you what is the form of the stones, what is the types of the stones. Now let's not make mixture. Let's just understand what is the necessity of this problem. Okay, inflammations usually can be in two main forms, and you study today in your pathological anatomy. You can have acute and you can have chronic. In case of acute inflammation, usually we have very short time of the development of the signs and symptoms, and unfortunately, in majority of the cases, it gives unreversible changings inside of the inflamed organs. For example, necrosis. And what is important, guys, for the majority of acute problems, again I say, time from its start and time up to formation of, up to mortal complications is very short. Usually it is hours, maybe days, but not so long. Vice versa, then we have chronic form of inflammations. Usually it is very long-term problem. Signs and symptoms usually is not so much developed. Pathological changings is not so acute. And instead of, for example, putrefaction, we have sclerotization reactions. Yeah, aggressive proliferation of fibroblast, formation of the collagen, yeah, sclerotization of the structures and anything else which you studied previously. That's a, for the gallbladder also, inflammational process can be developed in these two main pathways, in acute form and in chronic form. What is the cause of acute problems? Usually, in majority of cases, it is complete obstruction of the bile pathways. For example, the same stone or tumor, which is make obstruction of the narrow pathways, yeah, and it is make high hydrostatical pressure inside of these liquid content structural units, and due to it, all cascade of the reactions, yeah. Reaction usually started from the vascular reaction, yeah, so-called catarrhal stage, then it goes to the phlegmona, formation of the purulent processes inside of the wall. And finally, it can give the necrotization and perforation. Same for appendicitis, no any difference. Same for any inflammation. Firstly, then your skin is inflamed, you see hyperemia. What does it mean? Vasodilatation. Then, after the time, you can see, for example, formation of the pus. And finally, if you will not treat it, you will see formation of necrosis, gangrene, for example. Of course, for small disorders like your fingers, like your hands, your immunity force is usually enough to resolve these problems. But then we speak about internal organ inflammations. Unfortunately, in majority of cases, our powers, it's not enough. And the medicine should work here. Medicine should make the treatment or therapeutical or surgical comparable with the situation, or combined in majority of cases. By the way, what will be happen if I will not make this surgery? If it is acute problem, as I say, a wall of gallbladder finally can be perforated due to the high hydrostatical pressure, violation of arterial supply, putrefaction, and we will have the bile flow into the peritoneal cavity. It gives the special bile peritonitis. It is sterile, but it is made huge junctions between different organs. They slip to each other. Because what is function of the bile, you remember? Emulgation of the fats. What is the peritoneum? Phospholipids. Peritoneum is destroyed, fibrin is produced, organs glue to each other, situation we call strangulational disease. Person very quickly die due to necrotization of intestine, Yeah, because vessels is blocked, strangulated, intestinal necrosis is formed, peritonitis, and mortality. Chronic situation, little another, guys. Obstruction is non-complete. We can have flow of the bile, but this flow is not enough. Again, we have not so awful, but increase of the pressure. It doesn't make so quick processes, but anyhow it is make the pathological disorders. By the way, guys, like the person who is worked a long time in the medicine, I want to say that there are the situations then the chronic problem is much more dangerous than acute. Who can tell me why?
Because it takes longer time and the disease will develop fully and affects all the organ systems.
But why you will be needed, friend? You are needed to treat the problem. Otherwise, why we need the medicine? But what the problem here? Chronic problem can be invisible and asymptomatical. That's why you will be not responsible to find this problem in the early stages and to treat until the organ will not lose its function. For example, until instead of the now gallbladder inflammation, we will have the abscess in the liver, lymphadenitis, lymphangitis, choledocholidiasis, abscesses of the liver, cholangitis, and why not? Up to the malignization. Remember, please, any chronic irritation make pathological changing, especially in epithelial cells. Why especially epithelial? Why especially epithelial? Huh? It's so simple, friend, because epithelial cells, it is one of the most, one of the most
Sensitive to stress.
No, one of the most actively divided form of the cells of the human body. The more is divisional rate, the more possibility of mutations. The more possibility of mutations, the more the chance to achieve the cancer. Remember, guys, it is not so hard. That's why any chronic inflammation in any epithelial structures can be stomach. For example, several days before, I told you that 1 from 5 complications of ulcer disease, it is malignization. Yeah, really? So guys, if we have chronic irritation of actively regenerated structures, remember papanatomy, dysplasia, metaplasia, stratification, anaplasia, and finally formation of the cancer. What is the cancer? Mutated cells, which is abnormally grown, divided, spread, by the way, by different ways. I don't have now time to read your oncology, but that is interesting. That's in case of chronic inflammations, touch wood of course, but we can achieve the cancer. Of course, it is not the cause, it is risk. That is important. 100 times I say, you guys, from this level, you should understand the difference. What is the risk factor? What is the etiological cause? Cause by itself can give formation of disease. Risk, no. Usually, risk factors should be cumulated with several groups to give formation. For example, genetical disorder with some chemical irritation, with some inflammation, with age, with gender. All of them together will give the possibility, but each one separately cannot give the formation of disease. I told you before, yeah, that for coronavirus, virus is enough. But for example, cold is not enough. Low immunity is not enough if you don't have the contact with the virus. There's a low immunity in cold, it is risk factors. Virus infection, it is a biological cause. This is the review of your microbiology, guys. Okay, let's continue. Anyhow, doesn't matter what is the cause of the problem, what is the possible complications of the problem. Treatment is simple. Treatment is one. Treatment is ectomical. I should remove the gallbladder. Nowadays, 2 possible techniques we can perform, open one and laparoscopical one. And again, guys, don't think that you will be free to choose what do you want. That's not so. We don't have nowadays better or not so much surgeries. Any surgery which exists up to now means have strong indication. And generally choice is simple. If it is acute problem, means inside of peritoneal cavity you will not see any surprises. Why? Because acute problem it is forms during short time. I will not have usually abscesses, stitches, scars, anything else. I will choose the laparoscopy because I will see the normal topographical anatomy. Vice versa. If it is long-term problem with God's know what inside of, and I must make big revisions, I must try to find the structures, I must try to find the ligaments. Of course, I will prefer open access to make the better revision of the space. Friends, then you open the peritoneal cavity, you don't see something like in this picture, yeah? Organ don't say, I am here, come to me. Everything mixed to each other, you must understand where is one, where is another, where is vessels, where is nerves. So that is not so simple. And especially if there are some changings of the specificities, yeah? Instead of one location, there are another location. Instead of one color, there are another color, and something like this. Okay, what about access? If it is endoscopy, 2 in right hypochondric, 1 in umbilicus. By umbilicus we make peritonization, we inserted our endoscope. Here we inserted our manipulators. Yeah. Open access, it is the oblique incision, cochlear incision, yeah, thank you very much. Approximately from the level of sternal line, little bit laterally, 2-3 centimeters to middle clavicular line up to here. Parallelly to the costal arch, 1-2 finger below. All the layers you cut it in same direction. You don't split here any muscle. Finally, you come to parietal peritoneum. Here you remember we study surgical instrument, special forceps which we call Mikulicz, curved and they have tooth. 4, 2 in far, 2 in near angle. You lift it, you put the sterile napkins under it. That is strong rule. Before opening of peritoneal cavity, you must separate it by sterile napkins, wall structures from cavity structures. Then you cut the peritoneum after lifting of it to upwards. Your assistant try to lift, otherwise you can touch to the organs, which is located inside there. Just make small aperture, usually inserted your 2 fingers inside of it, yeah. Again, lift the peritoneum and along of your fingers, using the scissor, yeah, usually not scalpel, but scissor, you cut in the peritoneum, then you put the Mikulicz's in the sides, and hold your hands like this. Assistant, usually, from the angles, inserted the hooks in the wall, of course not in the organ, for example, far above. Then you push it into the sides and lift the margin. Why from margins, not from sides? Because you can see that his fingers in the place of margins have higher positions. To not damage again the structures which is inside. Let's say here, then enlargement and in the same time lifting. Of course, thank you very much. Not so much lifting to make the rupture of the structures, but a little bit you lift it to not touch organs inside of the peritoneal cavity. But after this you see, guys, we take the biggest hook in the surgery, which is called liver mirror. Your assistant put it in the visceral surface. I think you remember that here we will have in the right lobe, yeah, if you will look from downwards to upwards, you will see here right groove, longitudinal, left groove, and between this groove you will see porta hemorrhage. Let's say right longitudinal groove, anteriorly forms by gallbladder, inside of its fossa, posteriorly by inferior cava vein. Yeah, this is good structural unit. So you need this fossa. You need this place because you must find the gallbladder. I want to remind you that we push the liver to upwards by the mirror. Mirror has big surface. Mirror doesn't curve to inside, otherwise you will make the rupture of a liver. Or it is splayed, or it is look to outside. And you make the ventrapedal position. Ventro, it means in front. Let's say the hilum come to in front, you see the, if it is endoscopical, you don't need it because endoscope is pushed below the liver in subhepatical space, and you see everything, and you don't need to move anyhow the organs. Because not your eyes is inserted inside of the cavity, but the endoscope, optical equipment. I must to choose now, by the way, despite which method I use, endoscopical or open, I must to choose now, my incision is finished. Access is finished, now I come to technique. I must to choose one from two possible techniques. One is called technique from neck, second is called technique from fundus. And again, guys, again I say you 100 times, I will tell you that you will not be able to choose what do you want. Again, there are indications. Again, if it is mainly fresh problem without some violation of the structural units, make the neck surgery because it is better. Generally, it is better. It is better because primary you find it main artery, you ligate the main artery, and you prevent any bleeding during your surgical performance. In case of fundus first surgery, station is another. You must to come finally to the main artery. But before you will reach the main artery, you will see a lot of the branchings of it. And each branch should be ligated, cutted, maybe possibly bleeded. Let's say neck first surgery is better only if normal structural units of hepatoduodenal ligament is kept. I want to remind you guys that, can you give me exercise book? Your gallbladder, if it will be gallbladder, anterior portion will be called fundus, posterior portion will be called neck, and it will go to the duct, yeah? Which is called cystic duct. You remember it's connected with common hepatic duct. Your gallbladder located not strongly horizontally, guys. Its back portion, it is curved and descended to down and to left. Because it's inferior, it has hook shape form. By the way, several peoples genetically have the big curvation here. And it can make also the problem with the flow of the bile. You can make simply ultrasound and it will be detected, yeah? It has hook shape. If this hook is very curved, the normal bile passage inside of the gallbladder can be decreased. By the way, again, risk factor for the stones, risk factors for the future formation of the stone. That's why it is located in such a way. Neck of it is turned to down, descending to the left. Why? Because it is entering inside of the hepatoduodenal ligament. Hepatoduodenal ligament started immediately from the porta hepatis, from the hilum. So what are you doing? You primary, then you make this incision. In lower part of your incision, you see the lesser omentum, yeah, which is located below. You come by lesser omentum to its more right compartment, the rightest part of your lesser omentum called hepatoduodenal ligament. And upper portion of your hepatoduodenal ligament near the porta hepatis. You will try to now open. How we make opening of it? You take injector with the liquid and dissecting forceps. By dissecting forceps, you fix the upper layers because it's double layer structure. Yeah? A little bit lifted, it is transparent, you see the place without structures. You injected the liquid between the layers, they separated from each other. Now again, you take dissecting forceps, lift it, make the small aperture, insert it groove probe, and along the groove probe you cut the upper layer of your, or by your fingers, it's also possible. You open the hepatoduodenal ligament upper portion, you see deviate from right side to left side, ductus choledochus, vena porta, arteria hepatica porta. Now you put your finger in the choledoch and you push it to upwards. Upwards, you see that your choledoch, like branches of the tree, split it into two terminal branches. Right one, it is the cystic one. Left one, it is the hepatic one, which is divided into right and left. And immediately up to this junction, you find the cystic artery. This is your main goal, to find this triangle A, which is called Galois triangle. Friends, nobody will not explain in such a way as I do it now for you. Use it, study. All another manipulations is simple, guys. Ligate the artery, endoscopically you apply the metallical clips, proximally, distally cut it. If you make open 2 in the proximal, 1 in the distal, again you cut it. Then you start to separate it, these bile ducts, half of centimeter far to this junction place on the cystic duct, you apply the ligature. Several millimeters far from this ligature, you apply arterial forceps. You don't forget it to put the sterile napkin below this place because some small leaking we can have. Then you take the scalpel and cut it. I told you don't make the long stump because we can have formation of false urinary bladder, gallbladder. Bile can come to this stump, during the time can enlarge it. Sometimes students say, sir, it's great, the new gallbladder will be grow. It's not great because this gallbladder will be inflamed in 100% of cases and perforated. Then you make it very short, some specialist ligate it immediately from junction place. Not big chance, but there are chance to make the narrowing of the common bile duct. That's a half of centimeter. It is the gold size for the future stump. Okay, you cut it. Now you take it from this arterial forceps and start to lift it to upwards. In another your hand, you take the Kupfer. This is the Kupfer. Usually it is arterial forceps with some sterile napkin in the tip, which is fixed. And you start, before to separation, of course, from 2 sides. You cut it the peritoneum, which is fixed the gallbladder to the liver. And now you started to make the blunt separation of gallbladder from liver surface between them, as you remember, we have loose connective tissue. So mainly bluntly. Sometimes you will need to make sharp manipulation. Also, if it is the chronic problems, we can have the dense threads, stitches. And here it will be even maybe necessary to make the arresting of the bleeding, because inside of them we can have angiogenesis, formation of the new vessels. So you will need to make ligation. Step by step you will come up to the fundus, and finally whole gallbladder will be removed, and you will have achieved this empty fossa. Now you will take the atraumatical needle and will make the non-interrupted or interrupted, how you want, suturing of right and left margins of the peritoneum. Manipulation we call peritonization. By the way, peritonization, it is one of the common manipulations inside of peritoneal cavity. Then you remove something. You must do your best to make the complete peritonization. Otherwise, again, production of the fibrin, gluing of the structures, huge amount of the problems which can be happen. If you need, before applyment of the last suture, insert please the rubber tube inside of this fossa. If you see, for example, there are some bleeding here, you try to arrest, but some small amount, 1 drop of the liquid, insert it, you will be more safe. But remember forever, I say you 100 times, drainage tubes, feeding tubes, don't remove from main incision. Make the counter aperture. Near the main incision, 2 centimeters far, perforated the bone, remove this rubber tube. If it is necessary, surrounding, put 1 suture to fix it in the aperture, to prevent any movement of it. And in the future, then you will not need it. For example, after 4 or 5 days, you see that no any content didn't come. Just push it down, backside. Even it's not necessary to close this, put the sterile bandage in this place 2-3 days, and that's all. Is it understandable for you? How we make the reverse surgery, fundus surgery? I think it's not so big puzzle. Firstly, you cut the peritoneum, Now again, now you apply, usually this is so-called bladder forceps, fenestrated forceps, but it is occlusional, it's not crushing. Not like the hemorrhoidal, yeah, which I show for you, which is crush the structures. This is occlusional, we call it Luer forceps or gallbladder forceps. You apply it in the fundus, it doesn't perforate it, but make the good gripping. And you start, yeah, you cut it, the peritoneum from two sides. Now you start to lift it, and during the separation you see the branchings. Branchings is ligated, cut it, until come to the same hepatoduodenal ligament, until to see the callo triangle, until to make the performance which I show for you. You can ask me question, you can say, sir, but what to do if same stone go down and enter inside of the choletach? That is usually endoscopical manipulations after cutting of the cystic duct. We have the special micro instruments which we inserted inside of the choletach. We can do it from the duodenum. That's why we can make the endoscopy and papillotomy. If it is necessary, we cut the papilloduodenum, we enlarge the aperture. And endoscopical extraction of the stone. If it is located near the papilla, much more better to remove it from duodenum. If it is located upwards, so you make the necessary methods of investigation. For example, cholangiopancreata duodenografia. You inject it inside of papilla, contrast, and make X-ray. And by flow of the contrast, you see the place of obstruction. You understand approximately where it is located, and according to it, you can retract the stones from upwards or from downwards, how it is necessary. Questions? Usually after the surgery, we make also, if it is necessary, drainage of subhepatic space. We can make the drainage of the right subdiaphragmatical space because they communicate to each other. Again, all these drainages, as I say, we remove from contact apertures, not from the main one. Do you have any questions about this performance? No? Super. Let's continue. Now, second problem which I want to introduce you, it is the main problem in emergency surgery nowadays. Yes. Huge incidence of appendicitis. By the way, we see that in, I don't like the statistical information which we have nowadays. Tell me why. Because from majority of the countries, due to the political situations, due to the specificities of some national behaviors, we don't have the real picture. Let's say, usually I use the statistical information. By the way, in Armenia there are normal US, European countries, they should. But you know what the problem? Then you take the US statistical information, you understand that this is not the same what we have, for example, in Africa or in Middle East or in other regions. This is the problem which we have nowadays, that statistical information is not true and it's not deep. But anyhow, by my country, by general situation, I can say that incidence is very huge. More than 50, 60 million new cases we have every year of the appendicitis and so many surgeries. And then you make the appendectomy, survival of the persons is near the 100%. Then you don't make appendectomy and it gives finally perforation and formation of the peritonitis. By the way, two forms. We can have local, which we call appendicular abscess. Lucky persons, generally, I want to say, with long greater omentum, it is separated the place of the inflammation by the gluing. And the process primary was local. Secondary, of course, pus can perforate anything and can be spread it to the whole spaces. Yeah. You understand that if the pus perforated the bones, soft tissues can be perforated simply because it has proteolytic ferments, as you remember. Yeah. Okay. Again, translation maybe. Appendicitis, inflammation of the appendix. Again, inflammation, 99% it is acute. It means very short term, very rapidly developed, thrice more rapid than the inflammation of the gallbladder. You can ask me why. Why inside of appendix inflammation is so rapid? Why, for example, in gallbladder it will not be developed? For example, perforation will not be happen after 2 days, 3 days. But for appendicitis, after the hours it can be happen, even not days. Friends, make this movement and you will listen the wind in your head. This is the problem. You study 3 years in university. You must know that it has huge amount of lymphatic structures in the wall. Lymphatic structures, that is the first structures which is involved in any inflammation. This is the natural barriers of the human body. Don't forget that appendix for us, it is not the digestive, it is the immunity structure. Sorry, we are not the rabbits. For rabbits, it makes, for example, the digestion of the cellulosa. But for us, no. For us, appendix should be absolutely empty. It will not contain any fatties. And one of the causes of its inflammation, it is the parts of some substances, fatties, foods, stones, fruit stones, parasites, inside of its lumen. We don't have now the proved one explanation because it is a multi-etiological problem. A lot of different situations. They say main theory of inflammation, it is obstruction. Obstruction from inside, mucus is accumulated, the hydrostatic pressure is increased, lymphatic structures is inflamed, vascularization is increased, catarrhal stage. Because the content is not sterile, it gives the phlegmonous stage, formation of the pus inside of the wall. Finally, it gives the formation of gangrene, and after the gangrene, we achieve the perforation. And the non-sterile content goes to the peritoneal cavity, and it gives the huge problem which is called peritonitis. So remember, please, this is very important. It has very short time. Then you have this kind of patient, guys. You don't do for him hard methods of investigation, which is need a long time. Generally, it is the physical methods, palpation, it is the clinical sign and symptoms, and maximum ultrasound. That is the clinical minimum which is necessary to put the diagnosis and to go emergency to the surgical room to make this performance. Okay, performance is not hard if the appendix has typical position. Let's say you started generally from your incision, again, 2 types of technique. Endoscopical and the open one. And again, everything is connected, how it is complicated or not. More it is complicated, the more necessity of open access. More of this usually open access we choose for atypical positions. Because you would make the huge revisions to find where is your appendix. Do you understand me? Anyhow, for open access, you remember McBurney incision. Pen is connected now, right anterior superior spine with umbilicus. You split it into 3 equal parts. My third finger located now between middle and lateral third. This is McBurney point. By the way, due to the specificity of innervation of appendix, mean pain will be projected in the same point, in the McBurney point. And appendicitis, in the future you will study, guys, has the unique clinical sign and symptoms. It is the peritoneal signs, due to the irritation of the peritoneum, because appendix attached to the peritoneal cord from backside. And it also, behind of it, we have the branches of the sacral plexus. So we can have projection of the pains into the lower extremity, especially if you have big movements, flexion in the hip joint, rotation external, so it will give the sign. Rebound tenderness, then you press and quickly remove your fingers by the waves of the peritoneum, much more painful than you remove fingers instead, then you press it. Not so developed nausea, vomiting, subfebrile temperature, sometimes constipation, sometimes vice versa, diarrhea. There can be the problems connected, for example, cachexia, the person will not eat because it is painful, But after we will have development. Instead of the local pin, we will have diffuse pin and muscular rigidness. Defense, we call it. Why? Because instead of the appendix, we will see inflammation of whole peritoneum, which is called peritonitis. It will be perforation. Anyhow, guys, from the Mark-Bournet point, we make incision. You remember 1/3 above the imaginary line, 2/3 below, approximately 7-10 centimeters. For the children's, we descend incision to down. We call it Lenander incision because appendix has more lower position. Or we make the right pararectal inferior incision, which is more medially located than the previous one. Anyhow, you open the peritoneal cavity. Inside of the peritoneal cavity, you find the cecum. Cecum is located below the iliocecal joint. Yeah, above iliocecal joint, you have the colon. And along the taenius of the large intestine, you descend it to down. You remember in the base of the appendix, all taenius fuse to each other. That's a finding of base of appendix is not problem. Much more problem to find the tip of it. And it can have two positions, as I teach you before, typical position. Then you see whole appendix, which is descending from up to down, from right to left side. Usually it goes to the back wall and located in the level of the arcuate line, which is divided, graded false pelvis from each other. If you find it, you are lucky. It means you will make the simple surgery, which is called the retrograde appendectomy. Retrograde, it means from downwards to upwards. What you should do here, guys, everything is simple. You take the arterial forceps, or by one step, or by 2 steps. You clip this artery, which is inside of the mesentery, and which is called arteria appendicularis. Step is called mobilization of appendix. That's I take arterial forceps, I apply it into the mesentery. After this, by scissor or scalpel, I cut the mesentery. Artery is clipped, I will not have any bleeding. Then by ligature, I ligated this stuff. And I make the mobilization of appendix because fixing ligament is cut it. I achieve something like this. This is now appendix, no any ligature, no any ligament, sorry. And up to it here I will have ligated stump of the mesentery. It is understandable for you. What next? In the base of appendix, usually I little bit crush it by arterial forceps to make it plate, yeah? And then I apply the ligature on the tip of it, on the base of it, 1-2 millimeters far to it. I apply arterial forceps. I clip it. Again, I don't forget to put the sterile napkin because I will open the lumen of non-sterile organ. And I cut appendix with Immediately after this, guys, I take antiseptics, chlorhexidine, I don't know, alcohol, I don't know, iodinol, and start to treat the tip of this appendix because I open the mucous membrane, which is non-sterile. For the adults, after this, we have such kind of picture. This is the stump of appendix. Then you look from the side. It is ligated, of course. Surround of it, you apply seromuscular sutures, approximately 2-3 millimeters far away of it. And after this, guys, you ask your assistant to apply dissecting forceps on the tip of this stump and to push it inside of the pocket. In the same time, you tie this purse-string suture. You invaginated tip of appendix into the wall, not in the cavity. You form the pocket, look, and you close this stump of appendix by purse-string suture, which I apply here, and it is prevent any contact between open mucous membrane of appendix and neighboring structures. If there are somebody who don't understand, don't worry, I will not say anything bad. Raise your hand and I will explain it once again. Look, guys, that is simple. Now imagine that this is the wall of our sickle. Here I have the ligated stump of appendix. Tip of it presented by mucous membrane, which is non-sterile. Now I take the adragmatical needle with thread and surround it of this stump of the appendix. I apply seromuscular sutures. I don't tie any knot, just I start and finish in the same place. Now, my assistant apply the dissecting forceps in the tip of this stump and push it to inside. In the same time, I tie the knot. Then I tie the knot, I forms the sac. Why we call it purse string? Because it forms the sac. And I separated this mucous open structure from environment. Now you understand me or not? For the child up to 12, we don't do it because lumen of cecum is small and formation of such kind of the pockets can make obstruction of it. That's a for child meticulously treated by antiseptics. Sometimes what I'm doing, I little bit scratch the mucus. Of course, I put the sterile napkin to not lose this. In fact, little bit scratch the tip from this mucous membrane, to prevent. Again, I treat it by antiseptics. Let's say this is ligational method. For adults, we make invaginational method. Much more hard and complicated will be your life if your patient will have non-typical position of appendix. Usually in that case, instead of a whole appendix, you see only base of it. Appendix has some hook-shaped form. It is moved, God knows in which direction, usually backside, retrocecal, retroperitoneal. Don't try to move anyhow appendix to make it visible for you. 100% you will perforate the wall. That is forbidden. And here we make the surgery which is called anterograd, means opposite to the previous one. Now I will start to make separation from the base to the tip, and it will take a long time, much more than in previous case, and it will be more complicated. How I do it? First, what I need to do, I take the sharp pointed arterial forceps mosquito, I fix the thread inside of it, and by sharp point of it, I see the avascular part of the mesentery. I perforated it and inserted this ligature inside of this mesentery. Then immediately I ligated the base of appendix by this ligature. Again I apply arterial forceps. Between them I cut the appendix, and now I will see something like this. Appendix is cut, but mesentery no. I will start to apply arterial forceps into the mesentery, cut and ligate it portion by portion. How much? Up to the reach the tip of appendix. That's why my surgery will move me to the place of its location. Ligature, cutting, ligation. Arterial forceps, cutting, ligation. And you go up to the tip of it. Time is longer than necessary, and of course you can have the complications by the bleedings, but anything else. They say, no, you must do your best. Questions? No questions, there are 10 minutes. Work, read, ask me questions. I completely finish all theoretical part of my subject. Completely.